Okey I think we'll get started. I hope you guys can hear me. Let me know if you have any issues. Um, so my name's Namithaa. I'm one of the F1s, and today I'm going to go into a bit about diabetes. So it is aimed at final years, but it also means that it's quite concise and will be the essentials of what you need to know throughout med school. So diabetes, I would say, is something that's worth spending your time on because it can be in a lot of your MCQ, MLA questions, but also is quite a big OSCE station. So oftentimes the situation is you're in GP and you're counselling someone who's just been diagnosed or has just been started on a new medication. And so it's good to have an understanding of how we treat it and how it actually works so you can explain that to the patient. So today is going to be part one of the talk because it's such a huge talk. But we were going to go through, the following things. So we'll first go through normal blood glucose control in a healthy person, so you know what to expect. And then we'll go through what goes wrong with type 1 and type 2 diabetes. Then we'll go through how to diagnose it, the treatment for it, and we can talk through a couple of special types of diabetes before we jump into some SBA questions. So to start with, I'm just going to show you an example of a question that you could get. So I'll just read it out for you. So it's a 40-year-old female comes to the GP clinic for a routine health check. She reports that she feels well in herself, has a background of iron deficiency anemia, chronic kidney disease stage 3, heart failure, and psoriasis. Her HbA1c result comes back as 59 millimoles per mole. What is the next most important step? So you can see in your options, you've got a variety of medications that you can start. You can repeat the HbA1c test, or you can refer them for some dietary advice with the carbohydrate counting course. So you may or may not know the answer to this question at this point, but by the end of the session, we're going to aim to be able to answer this with some confidence. So take a couple of seconds to have a look at this, to gather your thoughts of what you think it might be, and we can come back to this at the end and see if it's matched up with what you thought. And just to add, if you have any questions at any point, just put it into the chat and I'll either stop throughout the session and answer them if it's relevant to that slide, or I'll come back to it at the end. Okie doke. So let's move on. So bear your answers in mind. So let's talk a bit about what normally happens in the homeostasis of blood glucose control. So our most important organ for this is going to be our pancreas. So our pancreas looks, if you zoomed in, a bit like this. So it has this cluster of cells called the islets of Langerhans. And inside it, we've got two main cell types that are involved in blood sugar control. So we've got our alpha cells and our beta cells, and they're antagonistic, so they do the opposite of each other. They also have, as well as the ability to release the hormones that are going to control our blood glucose, they also have the receptors themselves to detect a rise or a fall in blood glucose. So as with any process, we're going to start off with a stimulus that happens. So for example, let's say our blood sugar rises, and that is detected by receptors on the alpha and beta cells in the pancreas. So in response to that, our beta cells will secrete insulin. So insulin is a hormone that will travel through the bloodstream, and it has its effect on two main sets of target cells. So the first area it goes to is your muscles. So its aim is to essentially move the blood glucose from the bloodstream and into your muscle cells. And our glucose can then be used in respiration or stored as glycogen. Our second set of target cells are in the liver. So similarly, we're going to try and store our blood glucose away as glycogen in the liver. And that will overall lower your actual bloodstream glucose levels. It's a lot more happens than this, but I think for a basic understanding, you should just kind of understand where blood glucose moves to and why, to help you understand the role of insulin. So alternatively, let's say your blood sugar drops. So again, we've got our cells in the pancreas that detect this, but this time our alpha cells will release glucagon. So glucagon again travels into the bloodstream, and this time we want to promote our blood glucose to increase. So we're going to try and move it into the bloodstream. So what we can do is break down our stores of glucose, our glycogen, which we find in our liver, and then that is turned into glucose and released into the bloodstream. We don't do it so much for our muscles because we prefer to have a store of glycogen in our muscles. So anytime we do any activity, we've always got that backup in case we run out of any glucose that we have. Okay, and that will end up raising our blood sugar. So that is the basics of what happens. So let's talk about what happens in diabetes. So type 1 and type 2 diabetes are the two most common types that you should know about. So in type 1, it's an autoimmune disease, which essentially means your body is producing antibodies that attacks its own cells. So in particular, it attacks your beta cells, which we talked about are the cells that produce insulin. And the fancy name of those antibodies is anti-GAD and anti-ICA, which you don't have to memorize now, but will be helpful later when you're revising for exams. And essentially, if you destroy your beta cells, you're going to be able to produce less insulin in response to a rise in blood sugar. Less insulin, if you think about that pathway, then means that you're going to be able to move less of your blood glucose into your muscle cells and into your liver cells. So it just stays there in the bloodstream, travels to lots of different organs and causes the damage that it does. Type 2 diabetes works slightly differently. So this is where over time your body develops resistance to insulin. So your beta cells may be able to produce some insulin at the beginning, but because of things like high levels of fat in the blood, so hyperlipidemia or inflammation, this can cause your body to essentially be quite fed up of producing that insulin and essentially just stops listening to it. So again, you've got the same issue if you can't really move your blood glucose out of your bloodstream and into the muscle and the liver. Over time as well, that whole inflammation and increased levels of fat will also damage your beta cells. So you also in turn produce less insulin. So by the nature of these two things, you can tell that type 1 diabetes, if it's like an innate nature to attack your own body, is going to present itself in younger patients. And type 2 diabetes will be in more middle-aged patients when over time you've got that buildup of lipids and inflammation, etc. So overall, like we said, we've got less glucose uptake into cells. So you've got less synthesis of glycogen, so that store of glucose. And you've also got more gluconeogenesis, which is a fancy word for, because the body thinks it doesn't actually have enough glucose in its cells to use for things like respiration, it decides to produce even more glucose. So your liver in particular produces more essentially fresh glucose and releases that into the bloodstream, which makes things even worse. So complications of diabetes, so things that you should be asking about in your histories to try and figure out how well controlled is this person's diabetes, how's it affecting their life. So we'll start off with basic symptoms that you might present with. So the first one, polyuria, essentially meaning increased frequency of producing urine, happens because if you imagine you've got lots of blood glucose, your body wants to do something to try and get rid of it. So it tries to excrete some of it in the urine. Now, where glucose goes, if you remember from like chemistry A level, if you have a concentrated solution, then water tries to follow with it by osmosis. So the glucose in your urine attracts the water as well from your body, and essentially you just end up producing lots of fluid, lots of urine. Because you're losing a lot of water, you've then also got the polydipsia aspect, so that's increased thirst, where you're trying to replace your water stores. And oftentimes you'll see essentially a young person, like a 10-year-old boy, who has, and the mum is complaining that they're weeing a lot more and they're drinking a lot more, and she's not really sure why. In type 1 diabetes as well, if you imagine again, it's happening in these younger kids, they're not really able to regulate their glucose levels, store it away, and regulate where it's used in their metabolism. They're going to struggle with their growth as well. And so you often see a young kid who has failure to grow or unexplained weight loss. So other things to think about, they are at higher risk of infections, and that is because glucose is something that a lot of aerobic bacteria will love to use to survive. So you're essentially giving them a good environment to grow. So people will have increased risk of urinary tract infections, particularly because we talked about the urine being lost in the urine, the glucose being lost in the urine, and also increased frequency and worsening of skin and soft tissue infections. So let's talk a bit about, before we talk about diabetic foot, about micro and macrovascular complications. So microvascular, we're talking about the smaller blood vessels, capillaries, and smaller arterioles. So high levels of glucose can damage your eyes. So you've got retinopathy, can damage your kidneys, so nephropathy can damage your filtering system, and also damage your nerves, so cause neuropathy. So you'll notice like a loss of sensation, particularly in the peripheries. Then macrovascular, you've got your bigger arteries, veins that are being affected. So the biggest thing to worry about is increased risk of cerebrovascular and cardiovascular disease, so stroke and heart attacks. So the reason that happens is if you've got more glucose in your blood, it actually damages the walls of your blood vessels. And anytime you damage blood vessels, it either gives it an excuse to clot, which will reduce your blood flow to the brain and the heart, or it increases the chance that any fat traveling through the bloodstream actually deposits in that area, causing a plaque, and that also can narrow your blood flow. Similar reasons, you can also have peripheral vascular disease, which can, if you imagine, if you're blocking your blood flow to even your peripheries, then anytime that you're trying to walk or do any exercise, you're not getting enough blood and oxygen to the muscle cells in that area, and that can cause a lot of anaerobic respiration, essentially without oxygen, which causes the buildup of things like lactic acid and makes it very painful. The diabetic foot phenomenon is essentially like a mixture of all of these complications. So you can have the neuropathy, so the nerve damage that you notice. So if you imagine a person's not really able to feel what they're stepping on and soles of their feet, they're more likely to step on something and not realize it. So that causes some injury to the skin. And then on top of that, that injury then poses a risk for infection. And because they already have a higher infection risk, that infection gets worse than it would in an average person. On top of that, you've got issues with the nerve supply in terms of the sensation that can actually climb up further from the foot up to the leg. So it's called a glove and stocking distribution, which basically means your peripheries are likely to be affected first, and then you'll see it kind of gradually increase up the arm. Okay, so diagnosis of diabetes. So there are certain criteria that you need to meet to get an official diagnosis. So there are 3 main tests to know about. So the first is fasting glucose. So essentially you ask someone to not eat for 8 hours and then come in and take a blood test. And if their glucose at that point is at 7 millimoles, that means it's high at a baseline. So our normal range is 4 to 7 that our body can usually maintain our blood glucose levels at. The next test is called a random glucose test, which essentially is they don't need to fast. They come in and you notice that their blood sugar is naturally above 11. Or you can do something called an oral glucose tolerance test. So they will fast for 8 hours. They come in, you give them a drink containing glucose, and 2 hours later, you then take a repeat blood test. So essentially, you can compare their fasting glucose to the glucose after 2 hours of having the glucose drink, and it tells you essentially, is it high, or have they actually managed to bring that blood glucose back to normal, like a normal person with blood sugar control could do. So again, you're looking for a value of 11 or above. So then they've not been able to bring that glucose down below 11 after having the glucose, and they've not been able to produce enough insulin or listen to the insulin in bringing that blood sugar down. The last test is called HbA1c. So it's called, in long terms, as glycated hemoglobin, which basically means the percentage of red blood cells in the body with hemoglobin that have glucose attached to them. So you're looking at something equal to or greater than 48 millimoles, just essentially tells you that there's a lot of red blood cells that have glucose attached. There must be a lot of glucose that is floating into the bloodstream that it's able to bind to. So in order to actually be diagnosed, if you have any symptoms, so we talked about the polyuria, polydipsia, and in the type 1 diabetic, the weight loss, you just need one positive test. So it can be any of these 3 tests, and it just needs to be done on one occasion. If you come in and you're asymptomatic and you're just doing it as maybe part of a health, like a random health check, then you need to have the same test done on 2 different occasions. So that means they need to have, for example, their HbA1c on one occasion is, let's say, 49. It needs to be repeated, not the day after, but in 6 months' time, to make sure you're confirming that it's always quite high. And in terms of the months that we talked about as well, HbA1c is a really good indicator of what your blood sugar levels are doing over a period of months. Because it's not as easy as are you responding to a single meal. It's looking at how your red blood cells are binding to glucose over a long period of time. Generally, it's a good indicator of the last 3 months of your blood sugar control. Okay, sorry, just gonna have a look for the question in the chat. If the glucose comes down but slowly. So the question was, is it also diabetes if the glucose comes down but slowly? So all you're looking at is a single point in time. So they come in after 8 hours of fasting, you do their blood glucose, and then you give them that glucose drink, and 2 hours later you check it. And if at that point it is equal to or above 11, it tells you that they're not able to bring it down as quickly as a normal person would. It might be that it starts going down later on, because eventually they produce enough insulin, but it tells you that it's impaired enough that they can't actually bring it down as quickly as a normal person would be able to. So me and you would, after a normal meal, be able to bring our blood glucose down within an hour or so. Hope that answers that question. So let's look at some special circumstances where you can do extra tests to support your diagnosis. So type 1 diabetes, we talked about, is that attack of your beta cells, where therefore then they don't produce as much insulin. So insulin is a hormone, which means it's a protein, and the cells will produce insulin and store it for a while, and then it will get the trigger to actually release it when your sugar levels are high. And when insulin is stored, it's stored as something called proinsulin. So you've got the actual hormone attached to this extra molecule called C-peptide. And when insulin is ready to be released, it essentially splits apart and they're released separately. So you've got the insulin and the C-peptide released into the bloodstream. So in a type 1 diabetic, one of the indicators is if they have a low level of C-peptide, because it tells you that they also have a low level of insulin, because the two things really should be at a similar level because they're released at the same time. And we also talked about the special autoantibodies that your body can produce, and you can test for those too. It's important to mention, so HbA1c we said is good in the sense that it tells you blood sugar levels for the last 3 months, but it also has its cons. So if somebody has a condition where they have a high level of cell turnover, so that particularly red blood cells, so for example, if they are anemic, so they have iron or B12 or folate deficiency, if they have sickle cell disease, children and young people, so their turnover is going to be higher than an adult because they're constantly growing. In those conditions, you don't get an accurate reading of what percentage of red blood cells actually have glucose attached to them, because they could easily be broken down and replaced with something else. Type 1 diabetics, the issue with them, you can't actually use HbA1c with them because their blood glucose fluctuates the most in comparison to type 2. So it's very much blood sugar rises, they have their treatment, comes back down really quickly, because the treatment for that, which we'll go through, is insulin, which, like I said, in a normal person works really quickly. Because the blood sugar fluctuates so much, it's really hard to tell. It's really hard for there to be enough time for the glucose to bind to red blood cells, and so we can't really tell what it's like on a normal stable day. Acute illness as well is quite difficult, because you might have more breakdown of cells, or you might have an increased turnover of cells to respond to the illness. So again, you're not going to have an accurate HbA1c reading. So look out for those sort of conditions in your SBA questions if it comes up. Okay, so let's talk about the treatment for type 1 diabetes. So the mainstay is essentially insulin. So they're not able to produce enough, so we're going to replace it. So there's 2 main ways that you can do it. So you can have a regime of something called a basal bolus regime. So essentially you give them a long-acting insulin, which lasts up to around 24 hours, which gives them a baseline production of insulin that you could make normally. And so that's drugs like Levemir. And just before they have a meal, about 15 to 30 minutes before they have a meal, they can have a short-acting bolus. So that's injections like Act Rapid, which essentially help give them the extra insulin to manage the blood sugar that you're about to have with your meal. This essentially is like replicating what our body normally does. So we normally have a baseline production of insulin, and then we release some in response to meals and rises in blood sugar. So you're trying to replicate that in the type 1 diabetic. Some people might qualify for an insulin pump instead. So that's what you can see in this bottom picture here. Essentially, it's like called a closed loop system. So they have a sensor attached to their skin, which has a little needle that goes subcutaneously, so under the skin, able to detect your blood sugar levels. And it constantly records your blood sugar and sends that information to this insulin pump, which also has the connection under the skin and can release the appropriate amount of insulin to reduce that blood sugar to maintain it. Again, there's certain criteria to actually qualify for these because they're quite expensive, but a lot of type 1 diabetics will actually get it because they're often younger people. It's much harder to control their blood sugar in any other way. Monitoring wise, so traditionally a lot of people would do the finger prick testing. Obviously that's not very nice. It's daily to have it done not just once but multiple times after meals. So the newest way of doing it is called flash glucose monitoring or continuous monitoring. So essentially you'll see now people that have this sensor attached to their arm. It looks like a sticker, and on their phone or on another sensor type device, they can basically pass it over the sensor and it will tell them what their blood glucose level is at that point. Or in continuous monitoring, you don't actually have to pass it over the sticker sensor. It will just automatically tell you on your phone at any point. It's kind of got like a Bluetooth connection to it and will tell you your blood sugar. It can also in that sense give you alerts, like notifications if it's too high or too low. So that's your daily monitoring of it. But like we talked about, HbA1c is much better at telling you a general picture of your control over the last few months. And so we tend to repeat that in diabetics 3 to 6 monthly to tell you about their control. So sick day rules, essentially what to do if someone who's type 1 diabetic has an acute illness. So it's really important that they continue their insulin and they check glucose more often. So your body's natural response to illness is to also produce more glucose. So that's in response to both stress, but also if you're fighting an infection, you're producing lots of white blood cells, they need energy to fight off the infection. So your body naturally produces the glucose to help with it. So your real risk of your blood sugar running really, really high. So you need to importantly have your normal insulin as it is, and also keep an eye on your glucose levels to make sure it's not getting too high. Because eventually that can lead to a condition called diabetic ketoacidosis, which basically is where you've got lots of blood sugar, lots of glucose in your bloodstream, but it's not actually getting to your muscle cells, your liver cells, inside the tissue. So they haven't got the fuel that they need for respiration. So instead, they look for alternative fuels that they can use, and what they use instead is fats that you find, and a byproduct of breaking down those fats are ketones. Ketones are really acidic, and when they're released into the bloodstream, they will increase the pH of your blood. We'll get into this in more detail in the next talk, but just so you're aware that it's a complication of type 1 diabetes not being well controlled. Another thing to mention is that as a GP, which you may be in your OSCE, you tend not to manage type 1 diabetes on your own. You will put in a diabetic team referral so that they can provide that sort of MDT approach to it. So they're often quite young children and they need to be referred to a pediatric diabetic team who will help them with lifestyle changes and including like how to change their diet. And often they can be referred for this course called DAPHNE, which is called dose adjusting for normal eating. So essentially, instead of them having to cut out carbohydrate foods and high sugar foods that they love, it's managing those in reasonable amounts and knowing how to tailor their insulin so they can still enjoy those things that are sustainable for them. So type 2 diabetes is a bit more complicated and there's quite a few medications to know. So by no means, unless you have your finals, do you have to memorize this now, but it's a good idea to see this now and to become more familiar with it. Every time you see a medication, you'll then get reminded of it. and I've come up with like a few ways that help me remember it during my finals. So the main one to talk about is metformin. So how this works is we talked about how in type 2 diabetes, your body just gets a bit tired of listening to insulin. It has reduced sensitivity to it. So this will reverse that, increases your body's sensitivity to insulin, and also reduces the amount of new glucose that your liver produces, overall helping to lower your blood sugar. It's the only medication in diabetes that is safe to use in pregnancy, and that's worth remembering. So if someone is becoming pregnant or wants to get pregnant, you need to find a way to get them off all their other medications if they're on it. Common side effects, like with anything, nausea, diarrhea, you can switch to modified release insulin, which tends to reduce this side effect, and also can reduce your folic acid and B12 levels, so you might want to give them supplements to top that up. Lactic acidosis is quite a serious side effect of metformin, and because of the side effect, you want to stop metformin in situations where you're more likely to have acidosis naturally. So the main one really is sepsis and infection. So you increase your levels of lactate then, and in combination with metformin, that's going to increase it even further, and that can be really dangerous for your blood pH. So you want to stop metformin in any acute illness. The second thing it can have an effect on is your kidneys. So it's contraindicated in chronic kidney disease stage, well, with your EGFR less than 30, so around stage 4. And so you also want to stop metformin in acute kidney injury and in anyone that you can see their renal function is declining over time and they're entering stage 4 of CKD. Okay, so pioglitazone is another drug that we can use that increases your insulin sensitivity. Side effects of it that they love to ask about is fractures. I don't know why. And it's contraindicated, importantly, in heart failure and bladder cancer. These are really just rogue facts to memorize for your SBA. It's not super important that you know that. And it's not one of the most commonly used ones, but just now you've seen it once, you'll remember it. DPP4 inhibitors. So these are drugs that end in gliptin. And I used to remember it as like DPPs. It has lots of P's in it, and it has a P in the gliptin. This actually increases the amount of insulin your body produces. It's really good because it doesn't lead to any weight gain, which some of the other drugs do. So it's quite good to use in someone who is overweight. Sulfonylureas, so these end in I, so glimepiride, gliclazide, and I used to remember this as U and I. So yeah, you can see that U and I. And this also increases your insulin. A common side effect of it is that it works really quickly to drop your blood glucose. So it's really dramatic. So I used to remember it as like it's a really dramatic relationship and everything changes really quickly. So your blood sugar drops very quickly. And so it's important that you tell the patient that, because if they suddenly hit the opposite end of the spectrum and they have low blood sugar, they need to be aware of what symptoms they'll get. So they'll get very dizzy. In very serious cases, they can have seizures and have a reduced level of consciousness. They need to be aware that it's coming on. And other side effects of it, so this is one that causes weight gain and therefore is contraindicated in anyone that has a BMI above 30. It can also cause the syndrome of inappropriate antidiuretic hormone secretion, which is a special endocrine condition where essentially your body doesn't respond to the levels of water that it has, and it decides to retain more water than it normally should, which you'll come on to or may have already come on to in other endo lectures. SGLT2 inhibitors, so these end in gliflozin, so I used to remember it as GlowFlow, and essentially it's helpful to remember that because of how it works. So essentially it stops your kidneys holding on to glucose and lets it actually excrete it. So you're actually getting rid of more than you normally do. Because you're losing glucose, I remember that you're kind of losing weight as well. But if you imagine there's so much sugar in your urine, and like we said, bacteria love that, so you're likely going to have an increased risk of urinary tract infections. It can get to a point where you actually have breakdown of the skin around the area, and that's called Fournier's gangrene. Again, it's contraindicated in CKD stage 4 because it's quite harmful for your kidneys. I remember that by the fact that it actually works on your kidneys. So anything that affects it is going to make it worse. And then finally, you've got these GLP-1 mimetics. So that's some drugs like exenatide, which increase your insulin. This is not very common, and I wouldn't worry about side effects and contraindications and things. Just recognize the name. So if you'd like to, screenshot this page, or you'll see the recording later. But I've tried to really whittle it down to the things that you need to remember for your exams, because there will be a lot of information and a lot of different drug names that come up, and it's good to find a way of memorizing it. So, how do you decide what to do with someone in type 1 diabetes, and when do you give what? So, imagine they've just come in and they've had either that one positive test if they're symptomatic, or their two positive tests if they're asymptomatic. So the first thing you're always going to try in type 2 is lifestyle changes. So things like having a low glycemic index diet, of losing weight. And if you will then follow them up, let's say 6 months later, and you repeat their tests, and if you find that their HbA1c is still 48 or above, then we need to actually start some medications. So the first one we always try is metformin, and we start it at low dose of 500 milligrams once daily. Again, don't need to memorize the doses now, but it's often a good prescription question that they can ask you, and in your prescribing exams can come up in your finals. So let's say they've tried metformin, 500 milligrams for 6 months, and then they come back to you, get their HbA1c done again. If it's, let's say, it's around 51, so it's not quite as bad as our next limit, but it's somewhere in between, we can try just titrating the metformin up. So the maximum you can actually take is 2 grams once daily, so you can step it up slowly. If they've actually got a HbA1c of 58 and above, then we're going to need to add in another drug. So that's when you'll use double therapy, so add in any of the other drugs. And then if it's still above 58 after 6 months, then triple therapy, or you can at this point try insulin. And then if that's still not worked, then you can try a GLP-1 mimetic. So that's the exenatide at the bottom of the drug list that we talked about, which is really helpful in someone who is overweight, so has a BMI of over 35, or if they couldn't actually use insulin, it was contraindicated. Just to mention as a side note, if a patient at any point has at risk of cardiovascular disease, or has had a heart attack, or has heart failure, or has a Q risk score of more than 10%. So Q risk is basically the likelihood that a person will have a cardiovascular event in the next 10 years of their life. So a heart attack, for example. Essentially, any risk to the heart, you will add a SGLT2 inhibitor. So that's our GLO-FLO drugs, so our gliflozins. And it doesn't matter what they're on before. So I hope that makes sense. So remember, our first cutoff for starting any drug is that 48 after they've tried all the lifestyle changes. And then if we want to add more and more drugs, then our cutoff changes to 58. Okey-doke. So special types of diabetes. So one to know about is the maturity onset diabetes of the young, or MODY. Basically is an inherited form of diabetes that is autosomal dominant, so caused by the dominant gene. So if your parent has it, and let's say they have 2 dominant genes, you will get the condition. So you'll notice this in a young person that has features of type 2 diabetes, but they're less than 25 years old. So they don't have the classic type 1 symptoms, or they don't have low C-peptide or the autoantibodies with that. Instead, they have, so by exclusion, they've got type 2 diabetes. There's a special type that you can know about, type 3, which increases your risk of liver cancer. Again, is one of those rogue questions you might get. Don't waste too much of your time trying to remember that. But any young person, you might think type 1 diabetes, but don't forget to think about this rarer form of MODY as well. The treatment for this is just sulfonylurea. So that's the uinide drugs that we talked about. So that's glycosides, for example. Then you have gestational diabetes. So this is in diabetes that just occurs in pregnancy. And it can come up in multiple pregnancies, but doesn't exist outside of that pregnancy. So when they're not pregnant, we'll then refer to it as type 2 diabetes, essentially. So if they have diabetes during pregnancy, they can be at increased risk of diabetes afterwards, which we would then refer to as type 2. So risk factors for that, so if they've had it in a previous pregnancy, if they're quite overweight and their BMI is over 30, if they've previously had a macrosomic baby, which basically means quite a heavy baby that's above 30 kilograms, and if they have a family history of a first-degree relative with diabetes, any type of diabetes. So first degree means either your siblings or your parents, or if they're non-Caucasian. So the way you treat that is similar to type 2, where you start with your lifestyle measures, and then you can add on a drug, so our metformin. And remember that metformin is the only one, medication tablet-wise, that is safe to use in pregnancy. So if that doesn't work, our next step is insulin. So our short-acting boluses that we can give just before meals. If someone's fasting glucose if they're pregnant is above 7 when you start off at the very beginning of their pregnancy, then you straight away just go to insulin. And that's because the high levels of glucose aren't just going to damage mum, they're going to damage baby. You might as well just get on top of their blood sugar levels from the very beginning. So we're going to come back to our SBA that we had at the beginning. So I'll read it one more time, and in the meantime, you can have a think about what you think the answer is. So a 40-year-old female comes to the GP clinic for a routine health check. She reports that she feels well in herself, has a background of iron deficiency anemia, CKD stage 3, heart failure, and psoriasis. Her HbA1c comes back as 59 millimoles per mole. What is the next most important step? So take maybe half a minute to have a think, and you feel free to put your answer into the chat, or you can keep it to yourself, and I will tell you the answer in a while. I figured out how to create a poll, so feel free to put your answer into the poll. I've got a couple of responses. I can't see who's put what answer, so just feel free to go for it. Give a few more seconds. Okay, let's go through it. So the answer to this is to repeat the HbA1c in another 6 months. So big range of answers, and I think it can be quite confusing because there's lots of different like red herrings in the question. So the reason that this is the answer is because this woman has come in and she feels completely well in herself. She doesn't have any symptoms of diabetes. And if you remember, if someone's asymptomatic, then they need 2 tests that are positive on 2 different occasions. So she's had her single HbA1c result come back as 59, but we need to repeat it again to actually confirm her diagnosis before we go about treating anything. And remember that if we were to treat it as well, we're always going to start off with our lifestyle measures before we add in any medications. Okey-doke. So, second FBA. So a mother brings her 10-year-old son into the GP practice, concerned about his recent weight loss of 5 kilograms. Which of the following test results would not be appropriate to perform in this child? This one is quite hard, but it has a good learning curve to it. So again, just give it a go. I will put in a new poll. Okay, let's go through the answer. So the answer to this one is HbA1c. So the reason is, so this is a 10-year-old kid and he has recent weight loss. So in terms of diabetes, what we would be thinking is type 1, which is just more likely in this 10-year-old kid that's lost weight. And if you remember, HbA1c is inaccurate in type 1 diabetics because they have such massive fluctuations in their blood glucose that because they're not able to produce insulin or very, very little insulin, so they can't actually manage the highs as well as a type 2 diabetic could. So they won't do as good a job either, but they'll produce at least some insulin and be able to manage it somewhat. The other tests that I've put in here are for other autoimmune conditions. So thyroid function tests for hyper or hypothyroidism, which can be because of antibodies attacking your own cells. IgA and anti-TCG are for celiac disease, which again is autoimmune. B12 and anti-intrinsic factor is for pernicious anemia, which is basically B12 deficiency that happens because your body attacks this molecule called intrinsic factor that normally helps you to absorb B12 in the gut. An oral glucose tolerance test would actually be okay to use to diagnose this kid's type 1 diabetes. So that is why the answer is HbA1c. Just remember, in general, with anyone that has an autoimmune condition, because their body is already attacking itself in a way that it's not meant to, it's more likely to do that with other cells as well. So a person can have multiple autoimmune conditions. There is a link between having one and having another one. So last question, 55-year-old type 2 diabetic attends a GP practice for an annual diabetic review. He does not complain of any issues with his vision or sensation, but reports that he's struggling to lose weight. His BMI is 30 and his HbA1c is 60 millimoles per mole. He's previously tried lifestyle measures and is on metformin 1 gram BD, which means twice daily. His past medical history includes hypertension, a STEMI earlier this year, and atrial fibrillation. So what is the appropriate next step in his treatment? So have a think, and I'll make the last poll. Give it a few more seconds. Okay, let's go through the answers. So the answer to this one is empagliflozin, which all of you got, which is really good. So let's talk through it. So this is a person who's a known diabetic, so they're already on that treatment ladder. They've tried lifestyle, hasn't worked, and they've been started on metformin already. So if we're thinking about increasing his medications, then our new sort of limit is HbA1c of 58 or more. So he's hitting that, so we need to do something about it. Because it's more than 58, we're thinking about adding another drug rather than up titrating his metformin anymore. And he's actually already on the maximum dose. So he's on 1 gram twice daily, so that would be 2 grams total in the day. So in terms of what drug to add, so we've got different options here. So exenatide, which is number C, is that GLP-1 mimetic, and that was really, really far down on our treatment ladder. We've got sitagliptin, empagliflozin, and gliclazide. So gliclazide is one of our UNID drugs, so sulfonylureas, which can actually cause weight gain. So it would not be good to use in this person whose BMI is 30. So it's actually contraindicated. So then we're left with A and B. So A would be fine to use, but B is actually a better option because it's an SGLT2 inhibitor, and we mentioned that anyone who has had cardiovascular disease or is at risk of it, like this person who's had the STEMI earlier this year, should have that added to their treatment ladder. So if we're thinking about adding a drug, we might as well add that one, which kind of has the 2-for-1 benefit. And it also helps with weight loss because it's that glow flow drug, so the one that actually lets you excrete glucose in your urine. And if you think about it, you're almost like losing weight that way. So it will also be helpful for this person. So that is the end of this part 1, a bit of diabetes. I hope you found it useful. If you have any questions, feel free to put it into the chat now, or you can always email me. My email's at the bottom of the screen. And hopefully I will see you guys at part 2 of diabetes in April. Oh, and there is a feedback form. If you would kindly fill that in, let me know what you would like done differently or what I can add to your next lecture on diabetes. Lovely. Thank you very much, guys, and I hope to see you next month.